Many thanks for asking me to give a talk on drug interactions, particularly in common drugs used in pregnancy. My apologies for not being able to be with you today to do this live due to clinical commitments. But I do hope that in the next half an hour or so we cover some concepts surrounding this and hopefully provide you with a framework in dealings with pregnant patients and some of the common drugs that are being prescribed. So the aim for the next half an hour is to go through some definitions and mechanisms of drug interactions, and remind everybody a little bit of principles of clinical pharmacology and also what may be the results of drug interactions, particularly focusing on some of the physiological changes that may impact pharmacology, go through some of the commonly used prescribed medication in pregnancy, give you some examples, and then provide some useful resources. So drug interactions, as very familiar with most of you, is when the effect of a drug is altered by co-administration or stopping another drug. It could be not just drugs, it could be presence of food or herbal medication, or indeed smoking, be it nicotine or other products, can also have an impact. This results from the way the drugs work in the body, or the way our body handles drugs. It also involves the genes that each of us as individuals have as variants, and may have an impact on the way we metabolize or handle drugs. As well as all of those, it has something to do with our behavior, so our altered compliance with taking medication, or indeed not taking medication. So I'll go through each of these in turn briefly as a reminder, and provide you with some definitions of what pharmacokinetics, pharmacodynamics, and pharmacogenetics are, and what they may do with regards to drug interactions. So the drug interaction is important because as a result of that, there may be some toxic outcomes. So the drug interaction can give rise to the potentially harmful outcome, such as we see sometimes in patients who may be on antiplatelets, on anticoagulation, giving rise to significant bleeding or catastrophic bleeding. We see this when patients come in who've been on aspirin and anticoagulation, particularly in the elderly population, with cerebral bleeds or indeed gastric bleeds. There may be loss of efficacy, so this is going to be clinically significant, such as we may get by using antacids and thyroxine in a hypothyroid patient who takes omeprazole or PPIs for their gastrointestinal disorders and affect their absorption of thyroxine and a loss of its efficacy. It may be a desirable therapeutic effect that we get from drug interaction. We can see this when we employ 2 or 3 antibiotics in the presence of resistant organism. As an example, this could be when you have a patient with osteomyelitis or infective endocarditis, when the organisms are a bit more difficult to treat. or it may result in something that clinically is not significant. So going back to pharmacokinetics, there are 4 stages by and large in pharmacokinetics. It's how the drug is absorbed, and obviously the formulation of the drug is important, whether this is orally taken and then needs to be absorbed in the stomach, done through the gut and then go into the circulation, or whether this is given intravenously straight into circulation, or whether it's given subcutaneously or intramuscularly, and also other things that may come in to affect the absorption, such as the transit time for the gut, for the stomach to push the drug through to the small bowel for it to be absorbed, the pH of the stomach. The distribution is when the drug is absorbed into circulation and is distributed to the organs where it would have its effect. Metabolism involves by and large liver, but it can occur in the gut, and that's when the drug is either broken down into its effective format, or it's broken down in order for it to be disposed of. And excretion is when the drug is excreted out of the body, and this could, by and large, could be through the kidneys or through the gut. The importance of drug metabolism is particularly in this context of drug interaction, is when it comes to drug metabolism by a particular important enzyme known as P450 in the liver. This is an enzyme that breaks down a lot of the prescribed drugs. Some of the drugs that are exposed to this enzyme are what we know as enzyme inhibitors or enzyme inducers. If you have an enzyme inhibitor on board, it means that it will stop the activity of the enzyme, and then if you are given a drug that is metabolized by this enzyme, its concentration will increase and it may give rise to an adverse event. An example of this would be clarithromycin, which is an enzyme inhibitor. If it's taken along with simvastatin, it may increase the effects of adverse effects of simvastatin as a cholesterol-lowering medication, and you may end up seeing patients with myopathy. On the other hand, you have drugs that are enzyme inducers, which means that they would metabolize a drug a lot quicker. Therefore, the plasma concentration would be lowered and the effectiveness will be lowered. An example for this would be something like carbamazepine, which is an anti-seizure medication. It is an enzyme inducer. So that if a patient is taking an oral contraceptive pill, that may not work as effective because oral contraceptive pill is metabolized by P450. If a carbamazepine induces this enzyme, it metabolizes the oral contraceptive a lot faster, and so the effectiveness of that is reduced, and it could give rise to unwanted pregnancies. The other thing to mention is some of the drugs that are given are prodrugs, so they are not in their effective active form. They need to be metabolized in order to become active. So if the drug is like azathioprine or codeine, may be affected by the way that our body, in the form of our pharmacogenomics perhaps, handle these drugs, and they may not exert effectiveness. When it comes to pharmacodynamics, we're talking about drug bioavailability. So that is when the drug is absorbed and its effective concentration concentration is going to be playing a part in its action. So this could be by binding to various different receptors. It could be by actually its volume of distribution, how much of it is available, and how much of it is available for its action. And there may be drugs that have a competing action for the same receptor. So this could be an example of that would be where the efficacy of the drug is lost, where you have a beta-2 agonist salbutamol inhaler in a patient who has asthma, and then they are also on a beta blocker. So you have the same drug for competing for the same receptor, for activating the receptor, and the same drug which is inhibiting the receptor. And therefore, the efficacy of the beta agonist inhibitor will no longer be in existence because that receptor is being blocked by another drug. Or it could be that two medications give rise to extra effect of a medication. So an example would be an antidepressant medication, SSRI, such as sertraline or citalopram, and if you then given tramadol, it can exacerbate the effect and maybe lead to serotonin syndrome. Then we've talked about previously about intentional beneficial effects, so combining two antihypertensives, they can synergistically work on same receptors and reduce the desired effect that we are looking for. Finally, mentioning pharmacogenetics, this is where our genes may handle drug metabolism and effectiveness. We have variants in our genetics, and they can actually cause a problem with effectiveness. An example of that would be in the use of clopidogrel, which is an antiplatelet agent. It's used in patients with stroke or indeed in patients who have coronary artery disease. We have seen that some patients, unfortunately, will continue to have difficulties with their cardiovascular risk, even though they are on appropriate medication and they are taking these drugs. It is known that this produces some confusion, so patients don't have the benefits of their antiplatelet agent clopidogrel, and they have recurrent strokes or cardiac disease. Taking all of us on board and how our body handles things, we also need to be thinking about how pregnancy may affect the way the body deals with drugs. We know that in pregnancy, due to hormonal changes, there is delayed in gastric emptying, and that could mean that the bioavailability of the drug, so that's the effective concentration of the drug, may alter. It may be the peaks may vary in time. There is increasing cardiovascular output, increase in blood flow to the liver and the kidneys. If the drugs are being broken down in the liver, they may get broken down a lot faster. And if they are being excreted from the kidneys, they may get rid of a lot faster than expected, so the frequency of them may need to change. Equally, we know that as a result of cardiovascular changes, the plasma volume increases, so the drug concentration may vary. Again, the bioavailability may vary. If you have a drug that has a predilection to bind to fat cells, given that there is an increase in fat compartment, then the drug bioavailability may change. So all of these are things to take into consideration when we're dealing with pregnancy and medication. So how do we go about our detective work to see if we are in a position where we may make a diagnosis as a result of drug interaction, or indeed we'd like to avoid causing harm by introducing a new medication. So vitally, like everything else in clinical medicine is taking an appropriate and thorough drug history. So not only asking them what prescribed medication they're taking, but going into details of the dosing, how often, when are they taking it, what are they taking it with, are they missing any of their medication for various different reasons, being forgetful, being busy, not liking the side effects, not appreciating the importance of them, particularly in our population, the pregnant women, not taking it because they're worried about the harm that it may cause the baby. And it's important to particularly ask about supplements, over-the-counter medication, non-prescribed medication, culturally believed to be a good thing to take when you're pregnant to boost your energy levels. Asking about medication which are not in tablet form, so topical agents, inhalers, and paying a particular attention to allergies, and then perhaps summarising actually what they've told you and checking with them that you've got the correct information. So this is a list which is not exhaustible of all commonly prescribed drugs in pregnancy. The first few we see all the time, and they may not be there throughout the pregnancy and for a period. So iron supplement is a very commonly prescribed, and notoriously it interacts with a lot of other medication, and notoriously it's really poor with its absorption. We may prescribe antibiotics for intercurrent illness with urinary tract infection or upper respiratory tract infection or ear infection, anti-sickness, particularly in the beginning of the pregnancy with morning sickness. Vitamins along this line of folic acid and vitamin D, patients may be taking other vitamins and other supplements such as magnesium, calcium, which can actually stop absorption of other medication. Simple analgesia, particularly when we go into territory of non-steroidals or indeed opiate-based, they could interact. Antacids can stop absorption of other treatments and make them less effective. And then at the bottom, I've put down antihypertensives. So some patients may enter pregnancy on antihypertensive, known as having chronic hypertension, or develop hypertension during their pregnancy. And equally, the same applies for diabetes. So you either have gestational diabetes or enter pregnancies with diabetes. And I've put down anti-thyroid, but actually I meant thyroid supplementation. So we see people with hypothyroidism, but certainly with hypothyroidism. So I'm going to start by a number of cases that I have put together. Some of them more cases I've seen quite recently. The first case is about a young lady who is in her second trimester and known to be have hypothyroidism and is now needing to start iron supplementation for her iron deficiency. We know iron is poorly absorbed. It's affected if she's taking it with milk, tea, coffee. I know most of you advise on taking vitamin C or orange juice with it and taking it every other day. But you've got to remind her that actually if she is on thyroxine, iron can reduce the absorption of thyroxine, so she needs to be aware to time them so the iron is absorbed and the thyroxine is absorbed at different times. So give it a bit of time, otherwise the drug will become ineffective. Other than is going to be some antibiotics and some antacids also. Next is is a case of a young lady, again in the second trimester. She's had some urinary symptoms, and we now have an E. coli positive urine culture sensitive to 3 antibiotics. At this point, it's important to ensure that she's not taking any other medications because her antibiotics may be less effective. For example, simply if she's taken some magnesium for leg cramps, or for headache maintenance, or for her well-being or sleep, the nitrofurantoin is going to be less effective. I've put down some other medication that could interact with amoxicillin or cephalexin. Perhaps less likely that people will be on ACE inhibitors, but certainly if they are on sulfasalazine or mesalazine for inflammatory bowel disease or inflammatory arthritis, it can give rise to some nephrotoxicity. The third case is of a lady in her third trimester in omeprazole, and again is to reiterate that the combination of omeprazole or famotidine, antacid, or any kind of medication that would affect the lining of the stomach and the acidity of the stomach would affect absorption of thyroxine. This also includes calcium salts, magnesium salts, which may be over-counter things that they take. They also need to be aware of some commonly prescribed anti-seizure medications, or if the patients have HIV. Again, we've mentioned iron already, but milk, tea, and coffee can affect the absorption of thyroxine. The fourth case is of a lady who I've seen not so long ago. This was a bariatric lady who had asthma, had her bariatric surgery and IV drip at another country. She was started at her beginning of her pregnancy on Doltaparin due to her having a high risk for DVT, as well as aspirin for her high risk of preterm preeclampsia. She had prednisolone for a flare of her asthma recently and had started feeling nauseous with new gastric pain and shortness of breath. And when we checked her bloods at examination, she had a very tender epigastrium. Her HB had dropped by 3 grams. And this lady, and it was clear that she had about severe gastritis as secondary to combination of antiplatelets, of aspirin, steroid, and low molecular weight heparin. With low molecular weight heparin, you also need to be aware that some antidepressants can cause increased risk of bleeding, and also if they're given with steroids, the risk of bleeding increases. The last case to go through is somebody I saw about 2 weeks ago. This is an older lady who was again IVF pregnant, and right from the beginning of her pregnancy, she started exhibiting some symptoms of palpitation and shortness of breath, which had become worse by the time she was in her 30-week pregnancy. She had had lots of investigations, including blood tests. Her hemoglobin was normal, her thyroid function was normal, her using magnesium all were normal. She had a normal 24-hour test, she had a normal echocardiogram. When you took a history from her, she had a history of asthma and anxiety outside pregnancy, and for a number of years she had been taking the propranolol for her anxiety and salbutamol inhibitor for her asthma. She suffers with low-grade asthma, and the propranolol worked intermittently what she was taking. But outside pregnancy, both her symptoms were really well controlled. She fell pregnant and she completely stopped both of those. As the months had progressed, in addition to her changes in her pregnancy, the physiological changes in her pregnancy, the effect of anxiety not being on propranolol made the palpitations worse, and her asthma had got worse. So it was literally taking a good history on this lady with the benefit of the negative investigations that we could reassure her and appropriately start her back on her inhaler and giving her bisoprolol rather than propranolol, which is more of the selective beta blocker that would not affect the bronchial tree. Very often you prescribe anti-sickness medications or send people in a pregnancy with antiemetics. Zonvia has got a very good place, very safe. It works similar to cyclizine, so it does have some sedative effects. So if it's given with some antipsychotics, some hypnotics, some anti-seizure medication, in particular Trastram and lamotrigine, which are the two anti-seizure medications that we use in pregnancy more frequently, can give rise to increased sedation. And Dansetron, with combination with some medication, can give rise to hypokalemia or prolonged QT intervals. So it's always good to check if there are other medications. And equally with metoclopramide, it's an anti-dopamine medication. So if you give it with a dopamine agonist or an levodopa, it is very uncommon in pregnancy. You don't really have patients with Parkinson's, but you may have patients with dystonia who may be on these drugs, and it will affect the effectiveness of their medication. I'm sure this audience is very familiar with BNF and BNF Online. It's a very good resource to tap into when you, as a new drug, or you're worried about the effects of a new drug or the presentation of your patients with new symptoms. And this is as a result of interaction with another medication. So you can see here there is a section of interaction that you can look at. There are some links here that you may find beneficial. The first one, the drug interaction checker. You go into the website and you put your first medication and then your second medication, and it will tell you about interactions. The second link is particularly for maternity interaction checkers, and the last one also tells you about some of the dietary supplements that may have interactive effects in drugs. So how do we manage patients who we may suspect there is some drug interactions? So first of all, we've talked about taking a good drug history, then thinking about, have they been on these drugs, is it established or is it newly prescribed? If the therapy is established, then making sure that the patient has tolerated it, and if we need additional monitoring. If there is potential for dangerous or toxic interaction, you may be thinking about an alternative drug. If there is a low to moderate risk, you may want to be monitoring it, or indeed thinking about alternative drugs. Have resources where we can check our interactions, stopping the medication if there is an adverse event, and seeking help. We think that if the drug has a narrow therapeutic index, so if you fall outside that narrow therapeutic index, this will cause no effect, and a little bit more than it needs to be can be toxic. Think about drugs that may be enzyme inducers or enzyme inhibitors. When you prescribe in a second drug, or when the second or the third drug are taken, whether they would affect the efficacy of the drug, and always be aware of medications which are not prescribed but could interact with your prescribed medication. In summary, I hope that we've gone through the importance of taking a good drug history, applying our knowledge of clinical pharmacology in handling of the drugs to ensure that we are safe prescribers. ensuring that we are aware of how harmful some interactions may be, but also being aware that they may be of benefit. Always having drug interactions as our differential diagnosis for some of the symptoms or complaints that our patients present with, recognizing our common drugs that we prescribe and their interactions, and hopefully being able to check with either asking for help from a friendly pharmacist or a clinician, or using some software to check if there is some drug interaction. I'd like to thank you for your attention. I'd be very happy if anybody has any questions and would like to email me. I will endeavour to answer your queries and questions a bit later on. Many thanks once again.